Yeah. We'll do cardiovascular first, and then we'll go back to do respiratory. I'm going to kind of combine the blood medicine or the anticoagulants and the cardiovascular, just because they're kind of together already. So we'll do a little bulk of those. But now on your online on Pass Assured, it has like blood agents, and then cardiovascular meds are separated. And I don't even actually know that it talks about that you have a whole chapter on respiratory medicine. Some of it was included in like the peripheral nervous system drugs. So that's one reason. Yeah, I don't think there's any unit on them. So we're going to go over those today too. You'll still see those on there. So cardiovascular disorders are among the most common causes of death. You know that. It's because diet, lack of exercise. So these are some of your most commonly prescribed, like statins in particular, because of cholesterol level, cholesterol in food. So these disorders include angina. Do y'all remember what that is? Angina pectoris. We know pectoris is what? Chest. Angina is just chest pain. Okay, so not necessarily a heart attack. It can be a sign that you're at risk for a heart attack. But usually it's like you get little bitty clots in all those blood vessels that surround the heart. And so they cause like little bitty blockages. They don't necessarily cause long-term damage, but they cause this angina. And so in light of that, we'll talk about this in a minute, but you take the nitrates, and basically that like vasodilates everything. So shoots their blood pressure down, opens up those blood vessels so that they won't have that pain anymore, and that, that teeny tiny little clot can kind of move on. Hypertension, which we know is what? High blood pressure, myocardial infarction, heart attack, and then hyperlipidemia, high cholesterol. Or sometimes you'll see this written hypercholesteremia. So either one of those. But lipids are fats. So, okay, angina pectoris, it says often causes a sharp pain that's usually felt in the chest or the arm. And there are 3 groups of meds. So nitrates, like I said, beta blockers, and then calcium channel blockers. So we learned a little bit about those already when we talked about our classes. Nitrates, so this Emdur, this isosorbide, this is one that you can take all the time. This is like a regular medicine that people take. Now, nitroglycerin is usually a kind of like an emergency type drug or a PRN drug that, not always, sometimes it comes in a patch. So sometimes they'll have like a nitro patch that they wear all the time. But usually it comes in this little bitty tiny glass bottle, and there's really, really tiny tablets, like little bitty, and you actually put them under your tongue, and they dissolve under your tongue. So normally the instructions on nitroglycerin is that you take 1 tablet every 5 minutes times 3, okay, until it's gone. If after 3 tablets the pain is not gone, then they'll say you need to call 911. That's kind of your standard instructions on that, and that's something that you may want to know for testing purposes on here. But that's what usually the instructions are. Take 1 tablet, Q 5 minutes times 3, so 3 times. So as soon as you get that chest pain, take 1 tablet, wait 5 minutes. If you still have it, take another one. If you still have it, take another one. If it's still not getting better, then call 911 because you may be having a heart attack if that's not fixing it. Okay, so that's usually the instructions on those. And people will keep them with them. Beta blockers, we know they end in the LOL. Okay, so these work to, they work in a few ways. Enderol, both of these. Metoprolol is another one you'll see. The brand name for that one is just Toprol XL sometimes. Okay, so these work a couple ways. When they help dilate blood vessels, that helps with the angina. And they're also supposed to improve like how the heart contracts. That's why they work on both heart and blood pressure. And calcium channel blockers, diltiazem or cardizem, and verapamil, both of these are very commonly prescribed. Okay, hypertensive drugs, we know that there's several of these. We looked at them when we talked about classes. So drugs used to treat these are diuretics. What do diuretics do?
It's like for weight loss.
Do what?
Right? In the diuretics for like dieting.
They get rid of black water. Yes, they get rid of water. They make you diurese, okay, or get rid of water. So they work on the kidneys primarily, make you lose, like we talked about, if you eat a lot of sodium, sometimes you hang on to water, it causes edema. We talked about pitting edema the other day. I remember looking at pictures of that. So one of the things that these diuretics do is they make you lose that water. What else do they make you lose? Most diuretics. We talked about this. I know when we talked about it because Lasix was on your med list this week or last week. There's a particular electrolyte that they make you lose that you have to replace and take supplements for. Potassium. And we're talking about furosemide, Lasix. That's one that was on your med list. I'm not sure which week it was, last couple of weeks anyways. And that's one that you definitely want to be familiar with. So potassium as well. Anyway, and we'll talk about that more when we get to the renal drugs next week. Beta blockers, we just talked about those. ACE inhibitors, angiotensin II receptor blockers, calcium channel blockers, alpha blockers. So lots of different types of hypertensive meds. Thiazide diuretics. And this one I'm not actually even familiar with. That one on there. Hydrochlorothiazide, okay, HCTZ. Have we had that on our abbreviation list yet? Okay, that's an example, hence the name hydrochlorothiazide. It's a thiazide diuretic. Loop diuretics, and different diuretics have to do with where in the kidney they make you kind of lose that water. Okay, so when you look at a nephron, which is like the kind of the functional unit of the kidney, there's this what's called the loop of Henle, and it's one area where materials are kind of exchanged. Well, loop diuretics work in that loop, so that's why some of the diuretics are different. They work in different areas of the kidney to make you lose that fluid. Main one here is this furosemide and Lasix, and that's one you definitely want to be familiar with. Now, both of those, thiazide diuretics and loop diuretics, make you lose potassium too. So they help you get rid of fluids, but in doing so, you kind of deplete your potassium. Potassium-sparing diuretics hang on to your potassium. They don't make you lose that. So you wouldn't need to take potassium with those. Spironolactone is a very common one that's prescribed here. So is Diarenium. See both of those. Spironolactone probably see more often. Those are potassium sparing, so they actually have the opposite effect. Whereas these two up here, a side effect is with thiazide diuretics and loop diuretics, your side effect is hypokalemia. With potassium sparing, the side effect is hyperkalemia because it actually makes you hang on to even what you would normally lose. So. Other drugs, beta blockers, we talked about ACE inhibitors, Endopril, lisinopril, very commonly prescribed medication, angiotensin II receptor blockers, all those are, they all end in the ARTAN that we've had on our suffixes. That clues you in. Calcium channel blockers. This one's pretty common too. So a lot of these, whenever you look at them, they kind of give you an idea, not all of them obviously, but they kind of give you an idea that they're cardiac related, like vasotech, vaso is vessel or vein, actually, I think. Procardia, norvasc, like vascular. Okay, so use those kind of clues to help you whenever you go to answer questions about it. Let that kind of help you. Okay, well, that helps me eliminate these two because this is a urinary issue or this is a respiratory issue and this is called procardia, so it's got to be related to the heart somehow. Okay, so let that help you. Okay, antiarrhythmics, so medications that work to help the heart contract the way it needs to and with a rhythm that it needs to. Because arrhythmias are, that's a weird, have you ever seen that? Derivations? Anyways, it's just a way, arrhythmia just means that your heart's not beating at the rhythm that it should be. Arrhythmia means it doesn't really have a rhythm. Sometimes you'll also hear the word dysrhythmia. So like a bad rhythm. And so those are kind of used interchangeably. Okay, so away from the normal pattern of the heartbeat. So atrial fibrillation, y'all remember the word fibrillation? We talked about this week actually. Where instead of like the different chambers of your heart, instead of them pumping like they're supposed to, they just kind of quiver in place, kind of like they're having a muscle spasm almost. Well, you know, the atria are the upper two chambers of the heart. And so atrial fibrillation means those particular areas are kind of doing that quivering. Atrial flutter is kind of like a lighter, temporary form of atrial fibrillation. So it's not like it continually does that, but they may have an atrial flutter. They may feel it kind of going in and out of atrial fibrillation type feeling. Okay, but it's not necessarily. Sometimes with atrial fibrillation, usually if people, they'll say, oh, I went into AFib. Normally they have some kind of medicine. They'll try to take it at home. Okay, so they may have some medicine that try to kick them out of it. And if not, they have to go to the emergency room. And they'll try medication. If that doesn't work, they have to do what's called a cardioversion, where they actually kind of shock it back into place. Premature ventricular contractions. And that is exactly like what it sounds, you know. And we'll talk about this in anatomy over the next few weeks. But the heart normally, your atria contract, it kind of moves down like this. Okay, so the atria contract and then they relax. And while they're relaxing, the ventricles contract. Okay, they kind of work that way. That's what gives you your two sounds, is actually different valves in the heart closing at different times. Well, premature would mean that it's what? What do you think? It's premature, which means what?
It's going too early.
It's going too early. So that means the ventricles are contracting earlier than when they're supposed to. So you run into the atria and the ventricles kind of contracting at the same time. Okay, which doesn't work very well because then you got you got blood that's going the wrong direction. Ventricular tachycardia. Tachycardia is what?
Fast heart rate.
Fast heart rate. So that means the ventricles are beating too fast. Okay. And then ventricular fibrillation. Okay, ventricular fibrillation is not compatible with life. And so you cannot, atrial fib, you can be in atrial fib for a little while and fix it, convert it, and be okay. But ventricular fibrillation is like, if you go into ventricular fibrillation, you're going to have a heart attack. Okay? Because your ventricles, think about it, they actually pump blood out of your heart. Okay? Your atria pump blood to the ventricles. So if they're not functioning correctly, you can still get some blood moved to where they go. But the ventricles, particularly the left side of the heart, the ventricle pumps blood to all the rest of the body. So it takes lots of pressure. Okay? It's got to be really strong. So if it's just quivering in place and it's not pumping, blood is not going to get moved all over the body. Brain, liver, lungs, everywhere else it needs to go. Well, lungs, it's from the right side of the heart, but it's the same idea. Okay? Does that make sense? See the difference in the tachycardia means it's just beating really fast versus the fibrillation, it's just not beating. Okay? Now, VFib is what an AED works on. We talked about AEDs and how they only work on that one particular rhythm. Well, VFib is what they work on. That means you still have electrical activity going on in the heart, just not going properly. So that's what an AED tries to defibrillate, okay, the ventricles. Defibrillate. Make sense?
So if they didn't have a heartbeat, then the AED will work?
If they have no electrical activity, the AED will not shock them. It only shocks for that ventricular fibrillation. Now, you're not going to know that, so you just hook them up to it, and it's going to tell you
right.
Shock them or not, So you just follow that, and you keep it on them, even if it says it won't shock the first time. Sometimes doing CPR, you can knock them into that, and so it may work the next time. It may say, okay, now you can shock, you never know. So you want to keep it on. Don't just want to say, oh, it's not working, and take it off, because you want to keep it on there. Make sense? Okay, drug therapy for heart failure. So heart failure is the inability of the heart muscle to contract with enough force to properly circulate blood. So we know particularly congestive heart failure, and we talked about that before, it's like your heart muscle is just kind of worn out and just doesn't contract good enough to get blood where it needs to go and to keep up with it. Hence the name congested. So if the heart's not contracting well enough, it's almost like a traffic backup with the blood. So if the right side of the heart is not contracting well enough, it's going to get backed up in the lungs, because that's where it goes. It's going to get backed up in the body. The left side of the heart is not contracting right, then it's going to get backed up in the lungs. So sometimes you'll hear people say, oh, that I have right-sided congestive heart failure, left-sided heart failure, whatever. And that clues you in. That's one of the ways that they're going to know is if the lungs are affected or if it's, like a lot of edema. Usually people with congestive heart failure have a lot of edema, like dependent edema, which is just like gravity kind of holds on, because it's just not being pumped through the way it needs to. Okay, drugs used for heart failure include cardiac glycosides, like digoxin that we've talked about, diuretics, because they help get rid of extra fluid so that there's not so much fluid the heart is trying to pump and wearing it out more, ACE inhibitors, and beta blockers. And then there's a lot of things. Anti-hyperlipidemic drugs, so you can look elevation in triglyceride levels. These are all just types of cholesterol, so that's what they're going to look for. Anti-hyperlipidemic drugs are only used if they usually try diet and exercise first, supposedly. Sometimes I think they jump the gun a little and just give them the medicine. But examples of these, a lot of these, you'll see that coal in there, like cholesterol. So that's something to look at. In Fibrozil, this lopid right here has a lot of contraindications, or not contraindications, but interactions with other meds. So that's one thing. You'll see it sometimes written, I think there was one this week. It wasn't this week. Last week. Yeah, Lipitor, statins. It says you don't want to give this. So statins is a totally different kind of drug. You don't want to give with. Like one. I said that one of the reasons it can cause myopathy, muscle weakness. Niacin is another one. You'll see that one. Niacin, I've seen a lot. And then statins are kind of like your standard. And statins are like the most frequently prescribed drugs that they're on. Okay. Let's just so that we can kind of stay. Let's go to your. Let's go to the packet, the thick packet, and we'll do. We'll go ahead and go over the cardio drugs on here. They are on page 44. And we'll kind of go back and forth like we did the other day. Cardiovascular agents. Okay, 44. Arrhythmias. Says contractions of ventral and atria are not synchronized. Premature contractions, like we said, tachycardia, atrial flutter, atrial fibrillation. They're contracting before or faster than what they're supposed to. Membrane stabilizing agents. Look, slow movement, the way that these work, slow movement of ions into the cardiac cells resulting in a reduction of the action potential. Okay, cardiac, remember we talked about there's different types of muscle tissue. Cardiac has its own muscle tissue, and they actually send signals between each other. That's why those intercalated discs, remember we were talking about that in anatomy? They have gap junctions that actually deliver the message from cell to cell. Remember, and they branch, and that's so that they can do their like simultaneous action. Like that action potential is going to just, it kind of, the way that it goes, and we'll learn this in the next few weeks, but it just goes right down the center of the heart, the septum, and it goes back around. And that's how it beats. It's the action potential, that nervous impulse goes that direction the whole time. I mean, every beat. Okay, so one of the ways, like it's talking about here, powers into the cardiac cell, so it's going to slow down that action potential a little bit, so it's not going so fast, and it's not just doing that quivering thing. See, because remember, if those cells don't repolarize, they can't have another action potential. And so if it's going so fast and it's not having that good time, it's just going to be spastic. Adverse reactions: nausea, vomiting, dizziness. Look at it says procainamide and quinidine are extremely similar and have been interchanged in therapy. Lidocaine is a drug of choice for an emergency IV therapy. So you'll see that specifically in like a heart attack, for example. If one of these things is going on. So it's funny because you think lidocaine is just your, you think of lidocaine, you think of it like a topical anesthetic or something, but it's used for this too. Xylocaine is how it's used. Okay, inhibitors of neurotransmitter release and uptake. So this is another way that these work. Mechanism of action: these prevent the release of various transmitter and prolong the action potential. So again, make it longer so that it's taking longer for the action potential to go through, and you can get a good solid heartbeat. Adverse reactions: hypotension, bradycardia, so it can slow it down too much. Mental depressant, decreased sexual ability. Special considerations: this IV amiodarone must be mixed in a glass container. Okay, they actually, I think that was you talking about these. They actually have glass instead of like an IV bag. Sometimes they have to have glass containers, and they kind of look like a milk jug. And you turn it upside down, and it just hangs like that. Now it has to have another hole in it because of pressure inside. It has to be able to refill the area with pressure. So they're kind of, different. Potassium usually has to be in the glass bottle too. Amiodarone, like I said, is commonly there. Calcium channel blockers, as these prevent the movement of calcium ions through slow channels, resulting in a reduction through the atrioventricular node, which is just kind of like, there's different nodes in the heart, kind of like a bundle of, it's like the potential goes from one to another as it goes through. And y'all remember, calcium is required. This when we talked about neurons and how they pass an impulse to another. Calcium is required at the end of those axon terminals where the neurotransmitter is released. It takes calcium to be able to do that. So those axon terminals have to have calcium to release that neurotransmitter to go to the next neuron. And so calcium channel blocker is going to release that and kind of inhibit that passage. Not completely, but slow it down for sure. Okay. That make sense? I'm so glad you learned anatomy. Adverse reactions. Bradycardia, again, it's going to slow it down too much. Hypotension, slow it down too much. Heart block, which is another like abnormal rhythm of issue. Cardiac failure, constipation, headache, dizziness, diltiazem, and braphenol, like we said on here. Congestive heart failure. So it says the pumping ability of the heart is unable to meet the needs of the body's tissues. We know that. We've talked about this quite a bit. Resulting in heart pumping less blood than it receives. So blood accumulates either in the chambers of the heart or it gets backed up. Fluid stays in the legs. Fluid stays in the lungs. It just gets backed up, just like, traffic. Okay, so look, lanoxin is the drug of choice because it increases the force of contraction. So digoxin is that, lanoxin I think is the brand name for digitalis. or digoxin, all those are the same. So it increases the force of the contraction. It's going to make it contract a little bit harder. It increases the force so it can push blood on out. Increases the effective refractory period and affects the SA node through direct stimulation. So it's going to tell it when to pump. Basically, it's going to slow it down and make it pump more completely, I guess is maybe a good word. Adverse reaction, nausea, vomiting, arrhythmias. It can cause arrhythmias itself. Special considerations, concern for digoxin toxicity. So look, a symptom of this is seeing like a greenish blue halo. So when they look at lights, there's like a greenish blue circle around it. That's a sign that they've got too much in their system. But now when people take digoxin, they have to have their blood checked pretty frequently. That's one thing, because they don't want that toxicity to occur. There's kind of a narrow therapeutic range. So the other thing to know about digoxin is it can cause, it doesn't say this on here, I'm really kind of shocked, but anyways, it can cause bradycardia. And so if people's heart rate is too low, they won't administer it. ACE inhibitors says we've talked about these, inhibit the conversion of angiotensin 1 to 2, and says the adverse reactions are dry, unproductive cough, dizziness, angioedema. So angioedema, angio is vessel, like blood vessels. And then possibly postural hypotension, which is where you stand up, get dizzy, blood pressure kind of drops a little bit. Special considerations, they have potassium sparing effect. So you have to watch out for hyperkalemia. Okay, so these can make you hang on to your potassium and not excrete it like you normally would. So in light of that, you have to watch potassium levels because they may get up too high, and that can cause its own heart issues. So again, these end in pril. We looked at those before. Next one's angiotensin 2, like we talked about on here. Cough again. Some of these are cough. These are all of your. The ones I started on here are the ones I've seen the most. Avapro, Cozar, Benicar. Sometimes these will be used in combination too. Like I've seen Benicar HCT, which means it has Benicar and hydrochlorothiazide together. So sometimes you'll see that. Sometimes, so if you come across something and it's got two names like that. Now sometimes they'll say just HCl. That doesn't necessarily mean that it's a combo product. Sometimes the brand name is just that. And that's just part of it. But like if it says Benicar HCT or HCTZ or trying to think of another one. Sometimes lisinopril might also have HCTZ with it. Okay, that means it's a combo and it's got that plus that diuretic. Hydrochlorothiazide is a diuretic. Okay, so it's a combo drug. Just FYI. Myocardial infarction, so the heart muscle does not receive enough oxygen because of reduced blood supply, and those cells can die. So we know it can be prevented. We looked that up last year. Beta blockers should be used and tapered, after the occurrence. So beta blockers reduce the heart rate, reduce contractility, kind of slow it down, make it calm down a little bit so it's not working quite so hard. So you say not working quite so hard. That's not really the right word. It's going to make it be better again. Okay, but it really slows it down too. So adverse reactions are heart depression, bronchoconstriction. Okay, remember we talked about, remember we have beta agonists. That's what we use for asthma. Okay, remember that beta 2 agonist. Okay, like albuterol that opens up air passages. Well, beta blockers then will have the opposite effect on those. So it can cause bronchospasm. It can cause that closing up of that. It's just the opposite effect of the other ones. That makes sense? Impotence, fatigue, depression, bradycardia, again, so slow heart rate. And then LOL, like these, we know these and that. Okay, angina. So again, with the chest pain, it's an imbalances between oxygen supply and oxygen demand in the body, but specifically on the heart. So nitrates relax smooth muscle around the blood vessels. So you're going to have like dilated blood vessels, which is going to decrease the how much gets back to the heart is going to also really pull down blood pressure, because it's, you know, it's like we said the other day, if you've got a hose and you got, you know, X amount of water going through it, and all of a sudden it gets to a bigger hose, you're going to have less pressure. Orthostatic hypotension for sure. And then it says nitroglycerin inhalant is flammable. Good to know, don't be smoking while you're taking that. Nitro injection needs to be protected from light. But it causes a really fast drop in blood pressure, so you have to be really careful. And I put that dosage on here. Now, that's for like a PRN tablet. Transdermal patch, like I said, it can be used as a patch too. Calcium channel blockers, we just looked at these. Note the adverse reactions are constipation and drowsiness. Should be taken with food. Limit caffeine. Beta blockers, again, can be used for angina as well. Bradycardia. Beta blocker, bradycardia. It says mass symptoms of hypoglycemia or hypothyroidism. I'll cover those up. Okay, hypertension on the bottom. So diuretics just decrease that resistance because they help you get rid of fluid. Okay, so possible hypokalemia, like we said, low potassium, and you want to take it early in the day, because if they take it late in the day, they're going to be up all night going to the bathroom. Okay, so we want them to take it in the day, because it's going to make them go to the bathroom a lot. So furosemide or Lasix, I'd say is the most common one on there. Hydrochlorothiazide, very, very common. Spironolactone, now like we said, that one is potassium sparing, so that one actually has the opposite effect. And then tranturine and hydrochlorothiazide, those are combo drugs. That's on the next side. Calcium channel blockers, which looked at these two. ACE inhibitors, all kind of work the same way that they did for other issues. Beta blocker can be a hypertensive drug too. So some of these have multiple uses even within that. Look at the central nervous system agents on the page 47. So these specifically work in the brain in order to reduce blood pressure. Okay, so look, the mechanism of action, it says stimulate alpha-2 adrenergic responses in the brain and reduce sympathetic outflow. Sympathetic, remember, is that fight or flight, so they're going to reduce that outflow from the brain and to work to do that. So look, adverse reactions, drowsiness, fatigue, depression, fluid retention. So you got some kind of psychotropic side effects here because it affects the brain itself. So clonidine is a quick treatment for hypertension. You'll see some that'll be used as a PRN med, but also people can wear patches of clonidine too. These peripherally acting agents, and then Zosyn, Cardura, that should clue you in that it's a heart medicine too. Many pressors, you know, that's another idea that it's a heart-related medicine. Vasodilators, so these are specifically going to open up blood vessels, help reduce blood pressure, tachycardia, palpitations. Palpitations is like, and y'all may have had some palpitations before, but ever felt like your chest, like your heart is just starts beating really hard all of a sudden, okay, kind of takes your breath away? That's palpitations. Hydralazine is probably the most common one there. And then look, it lists these combo products. So an additive effect to lower blood pressure and hopefully reduce the number of side effects because they can have a lower dosage of each. So again, like low intensity benazepril and hydrochlorothiazide, see how it has a HCT? That clues you in that it's a combo drug, Divan HCT. Hyzar is commonly prescribed, Lotril. These are all some examples that I've seen a lot. Okay. All right, kind of hang on to that page there. And let's go back really quick to the PowerPoint. We'll do anticoagulants before we break. Okay, so we know anticoagulant. What would that mean? Anti is against clotting. Okay, so it says without clotting, it's possible to bleed to death. So there's reasons that we need to prevent clotting. Okay, if our blood vessels are really, really narrow because of plaque buildup, or if we are at a high risk for clotting and so forth. But at the same time, if our blood doesn't clot, then we bleed out. Okay, or we can't live without our blood. So we need, there's a mix in there that you've got to find. So it says when clot formation is not desired, however, anticoagulants can prevent those blood clots or thrombosis. So examples of these, heparin. Heparin is specifically an IV drug, and that's kind of more commonly used in the hospital for this. Now, the other thing that you'll see, this Heplock, they call it, they'll say, like, are you going to Heplock their IV? Okay? Heparin is usually what stays in the IV tubing if you're not using it. Make sense? So you know how whenever you have an IV, you got a little bit of tubing left over, usually that kind of hangs out so you can use it if you need to. Well, blood can clot either inside there or at the tip of the catheter that's on the inside. And so what you do is you kind of lock up that IV, you flush it with some sodium, flush it with normal saline, and then you put in, like a few milliliters of heparin, usually like 5, and that heparin actually stays in the tubing because heparin helps prevent clots. That helps to keep it clear and patent, keeps it open. Warfarin sodium is Coumadin. I know that was on our med list this week.
Yes.
So Coumadin is an oral drug that you take. You have to monitor it really closely. PTINR, that's that drug that I would talk about, or that blood level lab that we usually take. And then you have a few low molecular weight heparins. And it actually doesn't list the one that I've seen on here most common, but the one I've seen is Lovenox is used a lot. That you might write that one in there, Lovenox. You might write that in that thing. That's another low molecular weight heparin. A lot of times Lovenox is given after surgeries, like if somebody's had their knee replaced, they're at a higher risk for blood clot, specifically because of the work that they've done on their legs and because they're immobile. The more immobile you are, the higher risk for a blood clot you have because it's not moving constantly. Okay? So Lovenox, Lovenox. Lovenox. And Lovenox usually comes in a pre-filled syringe, like it comes straight like that from the pharmacy. It's already packaged and ready to go. And when you get it out, it already has the right amount in it normally, unless the doctor prescribes it like a specific amount. If you don't weigh as much as what's recommended in there, whatever. And it always comes with a little air bubble. This is one that you actually don't prime. We talked about, like when we were looking at giving shots, we prime the needle so that the fluid is at the very tip. Well, Lovenox is really bad for like subcutaneous tissue, and so, or even like uppers, not really subcutaneous because it's a sub-Q shot, but like your actual skin, your dermis, epidermis can be really dangerous for that and kind of like erode it away because it's so strong. So what you do is you take the medicine, you leave the bubble in, and so what that does is that bubble kind of gets injected into that subcutaneous tissue, and it prevents the skin on the way in from getting any of the medicine that would injure it. It usually bruises really bad. The areas where they get the injections, usually on the belly, and they say it burns really bad too. But that's usually given for 7 to 10 days after a surgery.
Good morning, Bulldogs and Dogettes. It is Thursday, February 19th. Happy birthday to